Welcome to the Impact Medicom podcast. I am your host, Anna Christofides. In this episode, we welcome Dr. Versha Banerji, who is a hemato-oncologist and associate professor at CancerCare Manitoba and the University of Manitoba in Canada. In this episode, Dr. Banerji discusses the integration of non-covalent BTKIs in the treatment of chronic lymphocytic leukemia. This episode is funded by Eli Lilly Canada. Hope you enjoy it.
Hello, everybody. My name is Versha Banerji. I'm an associate professor at the University of Manitoba. And today we're going to be going through a podcast or a video capsule called Integrating Non-Covalent BTK Inhibitors in Chronic Lymphocytic Leukemia, Navigating a Rapidly Evolving Treatment Landscape. These are my disclosures. I have grant funding from multiple bodies, and I do receive speakers, bureau honoraria, or consulting fees from multiple different industry partners. And I've participated as principal investigator for clinical trials for many industry partners and cooperative study groups. This disclaimer is to identify that funding for this learning opportunity has come from Eli Lilly Canada. We've been able to have full control over the academic content and presentation, and that any information that falls outside of the product monograph would be considered off-label, and I will do my best to identify any such information should it come up in the presentation. The learning objectives for this event are to differentiate between first generation or covalent and second generation non-covalent BTK inhibitors, address BTK inhibitor selectivity and the development of resistant mutations with covalent and non-covalent BTK inhibitors alike. We will also spend a part of this presentation discussing how non-covalent BTK inhibitors will fill gaps in addressing current unmet needs in the management of CLL in the future. For those of you that are watching this presentation or those of you that are listening to the presentation, there is a QR code that can be scanned. For those that you are listening to the podcast, the QR code can be found in the description of the podcast. The idea here is to understand the knowledge prior to the presentation and how it improves with the presentation. BTK inhibitors have revolutionized the care of patients with chronic lymphocytic leukemia. And those BTK inhibitors currently in practice are what are called covalent BTK inhibitors. These include ibrutinib, acalabrutinib, and zanubrutinib. They have provided critical treatment options for patients in both the salvage situation, rescuing patients from chemotherapy resistance, but also in providing access to care for individuals who may not have been eligible for previous types of therapy, such as chemotherapy. The main thing that goes into determining how we select treatments for patients with CLL is really based on the molecular phenotype. But the second piece, and the piece that we partner with patients for, is how these treatments may affect patient lives. And this is really based on the safety and the efficacy of the treatments. And this is dependent on how selective a BTK inhibitor is, as we believe some of the toxicities are due to off-target kinase inhibition. And thus, we are moving towards more selective BTK inhibitors in order to improve the safety outcomes for our patients. But over time, because these drugs are given continuously, the efficacy of covalent BTK inhibitors goes down as a result of mutations that develop. We are looking towards either different classes of therapies to treat patients in this situation, but we've also been witness to the fact that newer types of BTK inhibitors have emerged, and these are known as non-covalent BTK inhibitors that can be used despite the presence of mutations in covalent BTK inhibitors. The CADTH algorithm has been used in order to determine which treatments are available across Canada for the treatment of patients with CLL. In the frontline setting, in patients who are considered to have low-risk genetic markers, we have chemoimmunotherapy, time-limited treatment with venetoclax and obinutuzumab, or the combination of a time-limited oral therapy that's currently under review with a BCL2 inhibitor and BTK inhibitor, ibrutinib venetoclax. In the relapse setting, we really are looking at time-limited treatment options or continuous options, again, based on the molecular profile, but also what treatment the patient may have seen previously. But once patients have gone through these classes, either BCL2 or BTK inhibitor in the covalent setting, there is an unmet need for effective therapies in the relapse setting. When we think of very high or high-risk patients, which means they have a 17p deletion or a p53 mutation or an unmutated IGVH, most of the time, if possible, we will use a time-limited treatment option, which could include venetoclax obinutuzumab, or again, under review, the combination of venetoclax with the BTK inhibitor, such as ibrutinib. However, most patients who are in this very high-risk group are likely receiving continuous BTK inhibitors. Once these patients relapse, they would see the alternate drug class that hasn't been used previously, again, leading to an unmet need for effective therapies in the relapse refractory setting. Now, we mentioned earlier that the off-target effects are really what lead to the difference in selectivity for the different types of BTK inhibitors for patient treatment. And this is because in the second generation treatments and newer covalent BTK inhibitors, the off-target kinase inhibition is limited. And this is best demonstrated by visualization with a kinome tree, where you can see the specificity of the BTK inhibitor itself on the inhibition of BTK, but you can also see the off-target effects from that same BTK inhibitor. And the larger the circles are, the greater the degree of inhibition, the smaller the circles are, the less those kinases are affected. And this makes a difference when we're trying to understand how to select which treatment for which of these inhibitors is best suited for a patient. And that's because there's the potential for greater side effects with greater off-target effects. However, there could be greater efficacy if we can really narrow in on inhibiting the BTK kinase. And so that's a crucial, important, key determining factor in terms of the efficacy of the drug moving forward. So there's multiple different adverse effects that can result as a result of the off-target inhibition from these kinase inhibitors. And what we know is ibrutinib has been an effective therapy at salvaging patients who are resistant to different types of chemotherapies. They were also effective in patients who had very high-risk disease. However, the challenges that we saw because of the continuous nature of the therapy led to us trying to understand why patients develop significant side effects related to infection, bleeding, or cardiovascular side effects. And most of this was because that the off-target kinase activity directly affected different parts of either the immune system, the clotting cascade, or the cardiovascular system, leading to the side effects that we're most familiar with. As newer covalent BTK inhibitors were developed with this knowledge, we started to see that they had less of those off-target effects, and as a result, they had less heart-related side effects and less infection-related side effects. And as we use these treatments today, more people have shifted away from ibrutinib and are using acalabrutinib or zanubrutinib. Due to the continuous nature of therapy with the covalent BTK inhibitors, the mutation pattern has been able to be studied, and the most common mutation that is seen is a mutation with C48.1. Now, when it comes to ibrutinib and acalabrutinib, we have likely more patients with data, and it seems to be the C48.1S mutation that occurs in 90% of the BTK mutations, progressing on acalabrutinib or ibrutinib. However, there seems to be multiple different types of mutations that are present across the covalent BTK inhibitors at this site. And the main challenge with the mutation at this site is that the drug is unable to bind, and therefore we lose the kinase inhibition as a result. The difference between the covalent BTK inhibitors and the non-covalent BTK inhibitors is currently mutations do not develop at this one site, which enables patients who have potentially previously seen a BTK inhibitor and developed a mutation to respond to the non-covalent BTK inhibitor. Now, this decision is mainly made clinically as a result of the fact that we do not have mutation-specific testing clinically available. And that's something important to note in Canada. So in 2023, the FDA granted accelerated approval to pirtobrutinib for adults with CLL and SLL who have received at least 2 prior lines of therapy, including a BTK inhibitor and a BCL2 inhibitor. Currently, outside of compassionate access programs, pirtobrutinib is not yet approved in Canada. Pirtobrutinib is being studied across multiple B-cell malignancies. And currently, there's been a lot of clinical trials trying to assess the efficacy of pirtobrutinib in patients who are either previously exposed to BTK inhibitors or who are BTK inhibitor naive. And this is going to help us understand the efficacy of the drug in the setting of previous BTK use, and also the efficacy when BTK inhibitors have not been used. This will also hopefully give a little bit more information about the mutation profile in this setting. A phase 3 clinical study known as the Bruin CLL 321 has also been done in the relapsed refractory setting. In this particular patient population, a diagnosis of CLL and SLL would be confirmed. In addition, patients could have prior treatment with the BTK inhibitor or venetoclax. The patients were randomized 1-to-1 to pirtobrutinib or investigator's choice of idelalisib rituximab or bendamustine rituximab. They could also cross over from the standard arm with evidence of progression as confirmed by an independent review committee. The primary endpoint of this study was progression-free survival. We are looking forward to more data in the phase 3 setting to see how this is going to alter our clinical practice moving forward, as we hope in Canada that we would be able to use this for the same population for which the FDA has approved it in the United States. Another non-covalent BTK inhibitor is known as nemtabrutinib, and there's ongoing studies known as the Bellwave studies trying to address the efficacy of this drug in specific circumstances. In this particular case, this study is looking at relapsed refractory CLL patients or SLL patients who've been previously treated with BTK inhibitors and BCL2 inhibitors, and they are being randomized based on the presence of a C41S mutation. The C41S mutation, as you recall, renders resistance to previous BTK inhibitors. And these patients are being randomized to the presence or absence of mutations and to evaluate the efficacy of nemtabrutinib. The field is changing rapidly, and we're really trying to understand how to best select the patients for treatments moving forward. All we can say so far is the resistant profiles when we think of covalent BTK inhibition versus non-covalent BTK inhibition seems to be different. And how this difference is going to be used clinically is yet to be determined. Ideally, we want to be able to use the drugs in a sequence that allows for more options for patients. And we don't want to eliminate any options. And thus, as clinical trials are reporting, we'll start to understand what situations are best for these patients, as we want to have the longest efficacy and the least amount of side effects long-term as thinking for our patients' benefits. With all pipelines for investigations of novel therapies, we always have to start in early phase studies, usually in the relapse refractory population. Then we can move into randomized phase 3 studies, usually again in the relapse refractory situation. And in all honesty, we can see that there's been Canadian participation along the pipeline for the study of pirtobrutinib. We're now moving into the frontline study, looking at previously untreated patients as well. And this is going to help inform efficacy of the drug in the setting of different B-cell malignancies and hopefully help us understand the resistant patterns in these untreated populations. For nemtabrutinib, similarly, we are seeing accrual to studies both in the setting of chronic lymphocytic leukemia or other B-cell malignancies in the previously treated setting, but also in the untreated setting. And so we're looking forward to how these studies report, and there has been some Canadian participation in these studies as well. In summary, I think it's clear that as resistant patterns emerge with covalent BTK inhibitors, the non-covalent BTK inhibitors will be providing an opportunity for us to stay within a class to treat patients without potentially switching classes, or more importantly, may provide more options in patients who have actually seen both classes of drugs. We know that the selectivity of the BTK inhibitors improves the efficacy as well as the safety by minimizing the off-target inhibition. And we're really in an environment where both clinicians and scientists are working together to move the field forward in trying to understand novel ways of treating patients with these chronic cancers. And the fact that we can provide another alternative to a covalent BTK inhibitor and salvage patients who have seen multiple lines of therapy is a welcome addition to the treatment options for the future in Canada. With that, I would like to thank you for your attention. If you can please scan the QR code in the description at the end to test your knowledge and to provide evaluation of the program, that would be greatly appreciated. Thank you very much and have a great rest of your day.